So we were talking about the types of radiotherapy, and traditionally, you see, you already know that there are radiosensitive and radioresistant tumors. Radioresistant like melanoma, sarcomas, glioblastoma, and radiosensitive like lymphomas, germ cell tumors, or small cell carcinomas. There are, generally speaking, three types of radiotherapy, three large types of radiotherapy. One is the external beam therapy, teletherapy, also called teletherapy, which is divided in conformal 3D radiotherapy, which is, let's say, the previous stage, but is still very much used, the 3D CRT, the cutting-edge therapy with X-rays, which is intensity-modulated radiotherapy, and then, of course, particle therapy. When you don't use photons, both of these are using X-rays, but you use particles, either protons or carbon ions in the present stage. Then you have brachytherapy, which is instead this internal therapy. So you need to plant seeds, needles, radioactive in the tumor. And systemic therapy, where instead you use, for example, radioactive iodine or strontium that goes to the bone, or radiolabeled antibodies. This is radiation that goes a little bit everywhere in the body for doing what is known as targeted therapy. In this course, we will not talk about brachytherapy and systemic radiotherapy, which are very interesting, but these are for the medical physics course. We will only say a few things about teletherapy. So generally speaking, the first problem that you can ask yourself is, how can you have teletherapy at all? Because from the physics, we saw that the depth dose distribution for photons, apart from the initial buildup, is exponential, which means that if the tumor is here, the dose to the normal tissue will be unavoidably larger than the dose to the tumor. So you see here, for example, you have a tumor here. These are normal organs. I said this is spinal cord, this is the liver, for example, kidney. Now, if you want to shoot a beam in this direction and you want to give 100% of the dose, a given dose, say 2 gray to the tumor, 120% of the dose will be here, 110% here, and moreover, you have also those on the other side, 90%, 80%, and so on. So what is the trick? The trick is to use many fields. So you see in 3D CRT already, you can use one field in this direction and one field in this direction. And you see here, represented here, and you see that if you do that, you already have a lower dose in the normal tissue and a higher dose in the tumor. Of course, lower, if you only use two fields in this direction, it's not so lower. You see 50%, 60% of the dose here, so these are very high doses. So, but if you use more fields, you will spread the dose. So you will have a large dose bath, but the local dose to the organs will be much smaller than the dose to the tumor. So this is the principle of 3D CRT, 3D conformal radiotherapy, and this is an example of how it looks like. In this case, you see you have, this is a prostate. You have to get used to the color scale here. The red generally indicates 100% of the dose, orange 90%, yellow 80%, and then green goes from 60, 50, 40% depending on the intensity, and then blue 20, 10%. So you see the blue regions are less, let's say less, is relatively low dose, but you see that there are still regions here, for example, here that is yellow. The tumor is here. The yellow part gets like 80% of the dose. Now, as I told you, how can the therapy be conformal? The way you do it conformal is that you build compensators so that they are shaped exactly corresponding to the shape of the tumor, and so you can actually direct the field in a way which is very conformal on the tumor. This is also now essentially gone and has been replaced by MLC. MLC means multi-leaf collimators. So these are small leaves that you can move, and so you can create every shape of the tumor. And in principle, you can even move them during the therapy if the tumor is moving. But the state of the art now, very much used in most hospitals, not all, but in most hospitals now, is the intensity modulated radiotherapy. In intensity modulated radiotherapy, the difference is that you see, if you can see it here, I mean, this is a complicated tumor, very complicated tumor around the spinal cord with intensity modulated radiotherapy. You see many, many colors, large volumes, many, many fields, actually. This is 1, 2, 3, 4, 5, 6, 7 fields. 7 fields. But what is remarkable is that the intensity of the beam in the different fields is not the same. Let's say if you go back to this image here, like for example, in this particular beam where you go through the lever, you want to reduce the intensity of this beam, and then for compensation, you will have to increase the intensity of this beam that is not really going through critical organs here. So if you do intensity modulated radiotherapy, you will have hot spot and cold spot. But the final results, you can see it here quite nicely. You see, this is the single field shape. This is the dose per field, and this is the total dose. You see that the dose per field is always higher at the entrance than the tumor. The tumor is here, this is a prostate tumor. But now if you integrate, which is shown here, if you integrate all the beams, you see that the dose in the periphery is blue, so it's like 10%, 20% of the total dose, and the dose in the center is now red, 100%. So it's a very high conformity on the target. You change the intensity of every beamlets to reduce the impact on the critical organs. The result is very conformal. It's a very nice gradient from high dose to low dose. But the volume irradiated, of course, is extremely high. You expose the patient to a dose bath. So almost every organ is irradiated. So it's true that the dose is low, but relatively low, of course. We are talking about many sieverts, many gray. So the radiotherapy is a chain. So to go to the treatment is here, treatment delivery. You have to go through many steps. The first step is certainly imaging. Then the second step is segmentation. You see, segmentation is where you define the targets and the organs at risk. Then you actually do the treatment planning. So you decide how to irradiate the patient. You verify your plan, for example, in a water phantom. Then you have the patient positioning, so you fix your patient on the couch, treatment delivery, verification, post-verification, and then eventually you repeat 1 to 35 times, depending if you are in hypofractionation or in conventional fractionation regime. So quickly, you know, the imaging is either CT scans, computer tomography, or these days also very much MRT, magnetic resonance tomography, where you can see much better the soft tissue, while in CT scan you see better the bone tissue. Segmentation is particularly important. You see here, this is, for example, a brain tumor visualized as in a CT scan and in MRT. And then you have to define the target. And we will see how you define the target, because it's not obvious. It looks obvious here, but it's not so obvious. Also, very important, you have to define the organs at risk. So you have actually to contour those areas where you want to limit the dose, where you have threshold doses, so you cannot exceed the given dose. For the head and neck tumors, you know, these are all head and neck tumors, you have many critical organs. You see the parotid glands, esophagus, the cheek itself for mucositis, and so on and so forth. So the target volume, as I said, is not which is this one in principle, but what you see here is what clinically is called the GTV. The GTV is the gross tumor volume. So this is a gross demonstrable extent and location of the malignant growth. It's defined also as primary, nodal, or metastatic. So primary if it is the primary tumor, nodal if it is in a lymph node, so if you want to target a lymph node, metastatic if it is a metastasis. But around the GTV, the clinician has to design a CTV, the clinical target volume. The clinical target volume is a tissue that contains a demonstrable GTV and or clinical malignant disease that must be eliminated. So you don't see the extension of the tumor around the GTV, but you think that there are micro extensions that are not easily visible, and so you increase the GTV, building the CTV. And finally, you still increase the CTV for another quantity called PTV, which takes into account the uncertainty in the treatment, like positioning of the patient, movements of the patients. So depending on where is the tumor and how uncertainty you think is the delivery of the dose, you enlarge the CTV to the PTV to make sure that you really give the desired dose to the CTV. And this is how it looks like for the lung, for example. You see, for the lung, which is moving, this is a very nice lung tumor here. You see the lungs here. You see a very clear lung tumor in this position here. This is a CT slice. The tumor is here. The GTV is clearly visible, but you see that you have the CTV is here because you see something. You're not so sure. This is just a little bit thickness of the alveolar region of the lung, or is extension, micro extension of the tumor. So you design a CTV. And finally, because this is moving, you design a PTV very large. You see a very large PTV because you say, I don't know where will be the tumor, so I want to irradiate all these PTV. So eventually you irradiate the PTV. This is the target eventually will be the PTV. Of course, PTV will contain a lot of normal tissue. So ideally, you would like to have the PTV as close to the GTV as possible. But ideally, but in reality, you have to be careful because if it is too close and you miss part of the tumor, you will have recurrence. Now, and then you have to do the treatment plan. Now, the treatment plan, how is done? I mean, the primary information that you have to know to make the treatment plan is the target dose prescription, the dose per fraction, which is decided based on the BD, and the organs at risk. Of course, you have to know the organs at risk, and as much as possible, you have to avoid the organs at risk. If you can find geometries that can avoid the organs at risk, that's better. If you cannot avoid organs at risk, as often happens, you have to make sure that the dose is not exceeding the tolerance dose. You have two approaches to do treatment planning. One is the conventional or direct planning, where you know already the direction of the beams, and then you want to calculate the dose and to the organs at risk. But in the inverse planning, you do the opposite. You decide what is the dose to the PTV, and then you calculate the best way to put your beams in a way that is reducing the dose to the organs at risk, and you have the maximum conformity. Clearly, it's a mathematical, complicated problem. Takes like one night of calculation because it's even more because it's a the minimization of so many parameters is a procedure which is extremely long and tedious. And but eventually you come out with the perfect inverse planning. Patient immobilization depends very much on where the irradiation is. For the brain or head and neck region is the head, which is immobilized, as you see, with masks, with thermomasks that are built to fit the patient. You see here different masks, but also the abdomen can be immobilized with a thermomask or with a sort of grid that also gives abdominal compression. Abdominal compression is important to reduce the movement of the abdominal organs so that you can restrict their movement and you can reduce the PTV if you do abdominal compression. And you see the foam which is used here to fit the patient, to keep the patient immobilized without strong compression. It's done with a foam which is adapted around the patient. Beam delivery. So the typical beam delivery machine for X-ray, which is like 90% of the patients are treated with X-rays. So still, even though of course we are, especially in Darmstadt, we are strongly supporting particle therapy, this is the working horse of most clinical radiation oncology units. It's LINAC, so it's an electron accelerator, linear accelerator for electrons, and it's LINAC. Two types are shown here. These are commercially available. They cost now around 5 million euro. This is an old one, the Siemens Primus. Siemens is now out of the business, and that's another one is a Varian. Varian is one of the main companies for this treatment. The idea is very simple. You have a relatively long linear acceleration of the electron here. The electrons hit a target here in molybdenum, generally, meaning some heavy metal. You produce X-rays, and then the X-rays are directed to the patient. If you remember the lecture on physics, it would be better to have a very high energy, because then the depth dose distribution is more shallow. But there are two problems. One is that high energy means high voltage, so the whole machine is more expensive. And the second is that you will produce photoneutrons. So most of the LINACs in the market today are about 6 megavolts. So they produce 6 megavolts X-rays. The old LINACs that were 15 megavolts and 25 megavolts, they have a better shape, but they are too expensive, and there is too much risk of photoneutrons production. Now, you can use the LINACs to do radiosurgery. Radiosurgery, also called stereotactic radiotherapy, aims to deliver a very high dose in very few fractions. So it's so few eventually that you call it surgery, because if you do it in one fraction, it's comparable to the surgery that is done, of course, in one fraction. Now, this is possible thanks to what we call IGRT, image-guided radiotherapy, and is divided in general in SRS and SBRT. SRS is stereotactic radiosurgery, SBRT is stereotactic body radiotherapy. This is for cranial lesions that have the advantage that they don't move, while SBRT is for body lesions that unfortunately move. This is definitely a new frontier of radiotherapy, and now there are specific machines to do that, like tomotherapy. Tomotherapy is a fast-rotating, 360 degrees rotating entry that irradiates from different positions. Cyberknife instead is like a small LINAC. Usually at the end here, you have the LINAC, and you can move the LINAC in all, let's say, is not only in rotation, but you can move it in every direction around the patient. So it's a robotic arm that you can move, and that's perfect for it's called knife, you know, because it's for radiosurgery. Now, we discussed a lot. We said, why should this work? We saw when we defined the BED that if you increase the number of fraction, the BED at the same TCP decrease. So you say, why we want to use SBRT, and why it is safe to deliver 20, 30 gray per fraction? Because this is the problem. Even if you have the same alpha beta for the tumor and for the normal tissue, you see there is no advantage in fractionation. Still, how can you give 20, 30 gray one fraction? The dose to normal tissue will be too high. The trick is in IGRT, of course, in the fact that you can see now much better than you could in the past, but especially on the physiology, if you want. So parallel organs respond according to the mean dose in the tissue and in the organ. So if you have a parallel organ, the complication is related to the mean dose. The mean dose will be much lower than the tumor dose, because now it's the dose in the whole organ, but only part of the organ is traversed by the beam. So the radiobiological effect is much less than you can do if you calculate a BED, for example, for alpha beta equal to 3 gray, you know, a typical 3 gray for the normal tissue complications. Furthermore, the more conformal is the treatment, the lower is the mean dose relative to the tumor dose. So you have a situation where If you have parallel organs, typically, you know, liver, lung, kidneys, all kind of parallel organs that you can imagine, stereotactic radiotherapy is good. You can do it. Of course, if you have serial organ that respond to the local dose independently of the volume, then in that case you have to be very careful. So if you have the optical nerve in the beam, or if you have the spinal cord in the beam, or even if you have the heart, which is partly serial and partly parallel, you have to be very careful, because of course a single dose, the extreme hypofractionation can cause irreparable damage in the tissue. Now, this is nicely shown here in this example, which was published a few years ago. Just playing with the numbers is something that you can really do at home. This is now the NTCP, a tumorized effect. So same TCP, you calculate the NTCP using the LKB model for tumorized effect. So you have 2 gray, 35 fraction, so a physical dose of 70 gray, alpha beta 10 gray. These are patients with locally advanced non-small cell lung cancer, so it's a grade 3 lung tumors. And the 2 different techniques. One is the CRT, the 3D conformal radiotherapy, shown here, you see, with the 1, 2, 3 beams, and the other is tomotherapy. In tomotherapy, as you have seen, you have a full rotation. Now, there are now now you calculate the NTCP for 2 critical organs here. One is the lung itself, so you look for fibrosis in the lung. The other one is the esophagus. Now, the esophagus, be careful, is a serial organ, of course. The esophagus is serial. The lung is parallel. So let's take the lung first. This is the lung with IMRT. This is the lung with CRT. So, of course, the NTCP probability is higher when you use conformal radiotherapy than when you use tomotherapy. Tomotherapy is an advanced version of IMRT with full rotation of the beam. And you see that when you go to very low number of fractions, you do have an increase. That is what we have already seen. But especially for tomotherapy, it's not so strong. You see, up to 5 fractions, there is no difference between 5 fractions and 35 fractions. And even here, you see, you only go from a 10% NTCP to a maybe 14, 15% NTCP, even if you go to a single fraction. This is 1 fraction here. If instead you take the esophagus, the effect is dramatic. You see, you go from 35 fractions, very low NTCP probability in the esophagus, both with IMRT, with tomotherapy here in pink, and in green with CRT. But if you reduce the number of fractions, the toxicity immediately becomes impossible, much higher than 50%. This is very nice, I think, shows very nicely why we use SBRT and when we can use SBRT. We can use SBRT, we can use hypofractionation, we can even use single dose, which is single fraction, which is really surgery. You go 1 day to the hospital, you receive 1 fraction, you go back home and you're cured. Only if you have parallel organs. If you have to deal with serial organs, be careful, because then it's impossible. And this is now, let's say, a little bit a discussion on how you do the SBRT. There are, this is, let's say, the methodology. So first you have to do imaging and setup, very careful imaging and setup of the target. Then you do a CT verification of the tumor position in the stereotactic reference system, so in the reference system of the beam. Reduction of tumor motions, this is of course important. The tumor motion will force you to use a large PTV, and for stereotactic radiotherapy, you want to use a PTV which is as close to the GTV as possible. And then you give a heterogeneous dose distribution in the planning target volume. This is also interesting. You see, this is the PTV and this is the CTV. Actually, the dose is not uniform. There is, you see, this is because you don't care very much about uniformity here. You kind of overshoot. This is convenient because if you can overshoot, if you find a direction where you don't have organs at risk, you want to overshoot in that direction. You don't care about uniformity here. You have situation, you see, where you have 150% of the dose in the PTV, not 100% of the dose, and you are happy to do it because you see, with an inhomogeneous dose distribution in the target, a rapid dose fall off outside of the target can be created. You see, this is what you can do with tomotherapy, and this is what you can do with conformal radiotherapy. What you want in stereotactic radiotherapy is a very quick fall off. We will see very quick fall off. For me, always means particle therapy. That they are very sharp on the edge. But this is what the difference between overshooting in SBRT and the conventional treatment. So the main application of this SBRT is also known as SABR, stereotactic ablative radiotherapy. The main, of course, you must have small tumors if you want to do that, because now if you have large tumors, you need, in this case, you know, the problem is not the tumor control, but if you have large tumors, you will need large beams, and the dose to normal tissue will be unacceptable. But if you take stage one non-small cell lung cancer and oligometastasis, that are few metastases so that you want to treat, these are small tumors, less than 1 centimeter, and it's ideal to treat them with SBRT. These are examples of treatment plans. But this has been done now in many other cases, from hepatocellular carcinoma to advanced non-small cell lung cancer, which is more than 3 centimeters, and also localized tumors in kidney, prostate, pancreas, adrenal gland, prevertebral tumors is also a critical tumor, and so on. And to the point that you see that the comment is whether we should make surgery in stage 1 non-small cell lung cancer, which is a big question. If you want, this is a paper from a known surgeon, but he himself admits that the results with SBRT are so good that there is no reason to do surgery to a patient with stage 1 non-small cell lung cancer. You can go directly to radiotherapy. And this is even an extreme case of SBRT, which is done in the Sloan Kettering. Here they do single dose treatment. This is for renal cell carcinoma. You see that the standard results are in green, 24 gray. No, I'm sorry. The hypofractionation, the normal hypofractionation is in red, you see here. But then you have single dose treatments with a dose lower than 24 gray, same results. You see, this is the progression-free survival probability as a function of the time in a Kaplan-Meier plot. And but if you do 24 gray, you see that you get excellent results. So, and these are, you see, again, a comment on how SBRT can actually be used. Now, this result, though, I mean, this result triggers some discussion because it looks like, you see, there is a sort of new biology here. Because if you see, this is hypofractionation, this is single dose, a dose which is lower than 24 gray. But if you use 24 gray, you get like 90% local control, progression-free, as a progression-free survival. So it looks like there is a click. But in reality, if you do it carefully, and this was done in a paper you see a few years ago, if you look at all the data for stage 1 non-small cell lung cancer, using either 3D CRT or SBRT, you see the green points are 3D CRT in conventional fractionation regimes. The blue points are SBRT in hypofractionation 3 to 8 fractions, and the red points are single fractions, so like in the Sloan Kettering in New York. Now, if you calculate the BD, which is very easy, now you can do it yourself, for everything you can calculate the BD, and you look at the measured, the tumor control probability, you see that all these points essentially lie on the same curve. So what is hypofractionation doing in terms of success of tumor control is pushing the curve in this direction. So it's increasing the effective dose to the tumor, and this increase of the biological effective dose to the tumor eventually result in like 100% tumor control. This is now, of course, you can say why you don't do this with 3D conformal radiotherapy. You have seen why, because the complication rate will be too high. So you have to use SBRT, and you can push it in this direction. So the success of the hypofractionation of the SBRT, even of the single fraction, is simply due to the fact that you are increasing the BED. So this is a nice example of how the linear quadratic model, at the end is always the linear quadratic model, is still winning, is still giving us a lot of information. There are, however, problems with SBRT that are not completely clarified. One is repopulation. You say, how do you deal with repopulation? You see that the total duration of SBRT is shorter than the starting time of accelerated repopulation in tumors. So we can say, good, I mean, we don't have to worry about repopulation because we finish the treatment before repopulation starts. Repair would be a problem if to give this very high dose, you need a very long time. So if you take more than 20 minutes, like half an hour or 1 hour to give a fraction, then you can have repair during the irradiation, and this will reduce the effect. But this you can deal increasing the dose rate, for example, using the so-called flattening filter-free machines. So you remove the filter on the X-ray machine, which is due, to select, to make a more uniform dose, because if you remove the filter, you have many different energies. So some of them stop before, some stop later. So it's a more complex distribution, but the dose rate becomes higher, and you can give the dose. The last problem is still very unclear, the reoxygenation. Of course, if you go to hypofractionation or even to single fraction, you have to quit the reoxygenation. And this is strange, then you have success, because if you remember, the hypoxic part can be up to 3 times more resistant than the oxic part. So how can you give a single dose and treat the tumor? This is still something that has to be understood, let's say, still something interesting, but to be understood. And finally, the final problem is that the linear quadratic model does not work at high dose. But this we saw already. I mean, I didn't put the slide because we described it already when we saw the models of radiation. You can build models that are working also at high dose. Okay, we will stop now here again, and then we go to the particle therapy in the final part of this lecture. This was everything about the photon therapy.